Okay, we'll get started. Welcome to the webinar, Genetics and Genomics, the ins and outs of testing for patients with gynecologic cancer. My name is Kitty Silverman. I'm the Uterine Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information, please visit our website at sharecancersupport.org. We're very excited to be presenting this webinar in partnership with Sharsheret. Sharsheret, a national nonprofit organization, improves the lives of Jewish women and families living with or at increased genetic risk for breast or ovarian cancer through personalized support and saves lives through educational outreach. While their expertise is in young women and Jewish families as related to breast and ovarian cancer, Sharsheret programs serve all women and men. Just a little bit of housekeeping for today's webinar. All participants will be muted during the presentation. When both speakers finish presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. The chat section will be disabled. When asking questions, remember that the speakers are unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to introduce our first speaker. Peggy Cottrell is a certified genetic counselor and the genetics program coordinator at Sharsheret. She is a graduate of the Sarah Lawrence College Master of Science in Genetic Counseling program. At Sharsheret, Peggy consults with women and families and answers individual questions about their family histories, BRCA mutations, and personal risks of hereditary breast and ovarian cancer, and contributes to the development and implementation of Sharsheret's hereditary cancer resources and programs. Thank you for joining us, Peggy.
Oh, it's my pleasure to be here today. So let me start by sharing my screen, and then we can get going. So genetics and genomics, these terms are so confusing, and especially because we look for some of the same things when we're doing these kinds of testing, and it can be really very difficult to understand what is it that that we're looking for. So that's what we're going to talk about today. And so the first thing I want to start with is just explain really what the difference is between these two. Genomics is a bad word to use when we're talking about testing the cancer cells themselves for certain markers that may be present that can indicate a target for treatment. And so we're trying to make better terms, but in the meantime, what we're talking about when we say genetic testing for hereditary cancer is we're trying to determine what you were born with. And so when we look at hereditary testing, we want to look at your normal cells. And so we may take a sample of your blood, we may take a saliva sample, sometimes a skin biopsy may be necessary. And then we're looking at what you may have been born with. When we're testing the cancer for mutations, we're really trying to figure out what caused the cancer to develop. And very often that's not related to things that are inherited, but these are mutations still that happen within the cells in the body and cause cancer to develop. So it could be important to look at both of these. I'm sorry, my answering machine is going crazy. It can be important to look at both of these as part of the process of figuring out someone's cancer. So as a genetic counselor, these two types of testing, the one that I'm involved with is the one for hereditary testing. And BRCA1 and 2 are ones that we commonly look for. They're probably the most well-known of the hereditary mutations that we test for. Sometimes they are thought of as being related to women. And I'd just like to point out that men are just as likely to carry mutations in BRCA1 and 2 or in other hereditary cancer genes that we look at, just as likely to carry them as women, but men are a little bit less likely to develop cancer because of those mutations. And in particular, our audience, people with Jewish ancestry, and here specifically people who are Ashkenazi or families come originally from Eastern Europe, have a much higher risk to carry a mutation in BRCA1 or 2, and that risk is about 1 in 40. So who should be tested? So we look for clues for who should be testing in the family tree. We want to start by testing people who have been diagnosed. And those are the most important people to test because the testing could have an impact on their treatment. And testing the people who have cancer is the best way to find the mutation in a family and then test other family members for what has been identified. So those diagnosed with breast cancer, specifically if they are under 50 or have a triple negative pathology. We want to test women with ovarian cancer, all people with pancreatic cancer, all men with male breast cancer, prostate cancer, especially for those with high Gleason score or metastatic disease, colon cancer, particularly for those who are young, under 50, and uterine cancer, also for those who are young, under 50. Now, in any of these cases, those who have a diagnosis as well as a family history, that's going to increase our level of concern and improve the likelihood of the insurance company covering the cost of the test. And having Ashkenazi Jewish ancestry also increases our concern. In fact, the insurance companies will take that into account very often in determining whether or not to cover the cost of the test because of the increased chance that somebody Jewish would carry a mutation in BRCA1 and 2. But sometimes the people who are interested in testing are unaffected individuals and they've never had cancer themselves, but they have this family history of cancers, and you see the variety of cancers listed here. And so those are people who may benefit from having the testing done. So these days in the United States, most of the testing we do is done as a panel. So back when I was first practicing, we used to try to figure out what's the most likely culprit, what is the gene that's most likely causing the problem here. And that was because the cost of genetic testing was so high that to get the coverage for more than just a handful of genes was really difficult. But as technology has changed, the cost of genetic testing has plummeted. And so very often now, once you're testing for one gene, it doesn't cost that much more to add on a lot more. So here, if you look at my diagram, first the one on the left, you see breast cancer in the middle, and then the circles surrounding it, and those circles represent different genes that could be predisposing to breast cancer. And so if someone is diagnosed with breast cancer, it would be important not only to include BRCA1 and 2, but perhaps the rest of these genes as well. And then in the picture that's in the middle or on the right-hand side of the illustration, we see that multiple cancers can be associated with a single gene. So the example here is TP53, and this is certainly a very complex and difficult diagnosis in a family. When there's a TP53 mutation, it's called Lee-Fraumeni, and it can cause many, many kinds of cancer, even more than are in the circle surrounding that gene. And so even with BRCA1 and 2, while the main cancers that we're concerned about are breast and ovarian, there's also an increased risk for pancreatic cancer, for prostate cancer, for male breast cancer, and with BRCA2 for melanoma. There are also genes that are predisposing to gynecological cancers. And I've listed a few of them here. And also the genes associated with Lynch syndrome. Lynch syndrome is important to talk about because it causes a combination of colon cancer along with uterine cancer and ovarian cancer. And if someone has uterine cancer, the main inherited predisposition that we think of is Lynch syndrome. So what about getting an updated test? So it turns out that we've been doing hereditary testing for cancer for, I guess, more than 25 years now, commercially. And at the beginning, the testing that was done was a little bit different. So the technology back then was PCR sequencing. So most people who got the test had it done by PCR. And the technology back then could sometimes miss certain kinds of mutations, things that were either large deletions or duplications. Very often, because testing was so expensive, if someone had Jewish ancestry, they wouldn't get a full test. They would get a test that only included founder mutations. Now, what founder mutations are mutations that started in the Jewish population over 2,000 years ago, and over time became concentrated in certain parts of Jewish populations, particularly those from Eastern Europe. And so back 20 years ago, it was not unusual if someone had Jewish ancestry to do just looking at 3 mutations that are common in people with Jewish ancestry. And it was a way to save money if you couldn't get insurance coverage for the full several $1,000s cost of looking at BRCA1 and 2. You could just look at these 3 founder mutations for a couple $100s. Over time, the technology has improved. And so now next generation sequencing is available. And this type of testing is what made the cost of testing become so much less and makes it possible for us to now do panel testing. So with panel testing, everybody can be a genius because instead of having to look closely and carefully at a person's diagnosis and family history to figure out what test to offer, we can just order a big panel for everybody. And while that doesn't always make the most sense, by ordering a big panel, we make sure that there isn't something that we're missing just because it hasn't shown up in the family tree. And this is kind of a little bit, in a way, doing population screening. So when we do a big panel, we're testing for things that we really have no evidence that we need to be concerned about. But we're just looking at it because we can afford it, and we don't want to miss something. So whether or not you get an updated test has partly to do with timing. So we know when panels started becoming routinely available, and that's probably somewhere in the range of 8 or 9 years ago. And we also know that some of these smaller tests continued to be offered even after that time. So I sometimes have women who call me and ask, should I get an updated test? And even though their testing was done 3 years ago, it may have been still only for founder mutations because their insurance wouldn't cover the full cost of the test. So a small test was offered. So what I recommend people do is to ask their doctor, or you can be in touch with me at Sharsheret and ask me, is my testing still good enough? Is there updating testing that has changed what the recommendations would be for me? And so if you had only founder mutations, even if the test was done only 2 years ago, you would need to have an updated test. And again, so it's not that we want people to get tested every 5 years, because your DNA is not changing. What you were born with stays the same. What changes is the technology of the test and its ability to find things. So as our ability to find things improves, then updated testing can make sense. So what do people do who test positive for an inherited predisposition to cancer? So some people who test positive who have an increased risk for breast cancer may consider an annual breast MRI. And that can be a really important piece of being able to find cancer in those who are particularly at high risk. And the finding of the inherited mutation is often the ticket that you need to get this covered by your insurance. Some insurances are willing to cover this on the basis of a strong family history, even in the absence of genetic testing. So in colon cancer, someone with an inherited predisposition like Lynch syndrome would qualify for an annual colonoscopy, not something anybody would necessarily want, because colonoscopies are not fun, but at the same time, something really important, because with Lynch syndrome, people with Lynch syndrome are not any more likely than the average person to have a colon polyp, but polyps can change very quickly from being just a benign polyp to being colon cancer. For uterine cancer, there is screening, an annual transvaginal ultrasound. For pancreatic cancer, there is screening, but it is not well proven to save lives at this point, but endoscopic ultrasounds and MRCP, which is an MRI of the pancreas and associated ducts. All of these type of tests can lead to the increased identification of cancer at an earlier stage. Now, unfortunately, screening does not work for everybody. And particularly with ovarian cancer, there is no good screening that finds ovarian cancer at an early stage. And so some people will have risk-reducing surgery to reduce the chance that they will ever develop cancer. So sometimes people do this because of an inherited mutation. And again, other times there are people with a strong family history where no mutation has been identified, where individuals will pursue this as well. And so someone might have a bilateral mastectomy before their cancer diagnosis with reconstruction, or people might have both ovaries and tubes, a salpingo-oophorectomy, removed before cancer develops. Oftentimes people who are BRCA1 or 2 positive will have a hysterectomy as well. There may be a very subtle and slight increased risk for a more aggressive kind of uterine cancer, and those particularly with a BRCA1 mutations. And that's something that women discuss with their doctor on a case by case. And those with Lynch syndrome would certainly consider having a hysterectomy and probably removing the ovaries and tubes as well, since ovarian cancer is also increased with Lynch syndrome. So sometimes people will say to me, well, listen, Peggy, this genetic testing is a great idea, but I already have cancer. So how is this going to help me? And it's really important to emphasize how important the genetic test is for those who've already been diagnosed with cancer. So first of all, in terms of the family itself, positive results help to determine the meaning of negative results for other family members. So if everybody in the family, those with cancer and those without, all test negative, that doesn't mean that the cancer is definitively not inherited. It could be that it's related to something that we don't know how to look for yet. So someone who thinks that their negative result means that they're not an increased risk may be fooled. And so a close relative with cancer who has a positive result can help show that that family member's negative result is actually a true negative. That describes that they have not inherited the risk that's in the family. Sometimes those people who are diagnosed with one type of cancer may be at risk to develop a second type of cancer related to that same gene. And this we see very often in those who are diagnosed first with breast cancer and then go on to develop ovarian cancer related to BRCA1 and 2. And so certainly we want to know if someone who has breast cancer is at risk to develop ovarian cancer as well, and we save lives by doing that kind of surgery. And finally, and more importantly, as related to the rest of our discussion today, people who test positive for an inherited mutation may be eligible for the use of a targeted medication, and this could include something like a PARP inhibitor, with BRCA1 and 2, or possibly immunotherapy related to those who have Lynch syndrome. So I just want to quickly emphasize the importance of speaking with a genetic counselor when you're working on hereditary cancer. Genetic counselors understand the pros and cons of testing, and will explain that to you before your test is ordered. They will make sure that the correct test is ordered for your personal risk and insurance network. I have had callers who tell me that genetic testing was not covered by their insurance, and it turned out that was because it was sent to a lab that was out of network. And then genetic counselors are very good at explaining the options for those who are mutation carriers first. So even those who may have genetic testing ordered by their physician should consider speaking to a genetic counselor once they have positive results. So before I finish up, I want to again share a little bit about Sharsheret and what we offer. Our Genetics for Life program is what I am in charge of. And we have materials that can help people understand more about inherited cancer. These are some of the booklets we have. We have a private Facebook group that people can participate in for peer support. And people can give me a call and set up a time to chat, and I can answer, in those situations, people's personal questions about their own specific family tree and genetic testing. And while I certainly don't give out medical advice, I can certainly give people a decent amount of guidance to figure out where they go next with their particular situation. So I will finish here. If you are interested in being in touch with me, my email address is here, pcottrell@sharsheret.org. You can follow us on the multiple of social media channels, or give us a call at our toll-free number. And it's been a pleasure speaking with all of you today.
Thank you so much, Peggy. That was really interesting and very informative. Thank you. Now I'd like to introduce our next speaker. Dr. Roisin O'Cearbhaill is a medical oncologist. She is the research director of the Gynecologic Medical Oncology Service and the clinical director of the Solid Tumor Program Cellular Therapy Service at Memorial Sloan Kettering Cancer Center, with a joint faculty appointment at Weill Cornell Medical College. Her research focuses on the development of novel targeted treatments, cellular therapies, and immunotherapy-based approaches to improve outcomes for women with gynecologic cancers. I'll turn it over to you, Dr. O'Cearbhaill. Thank you.
Thank you so much. I'm just going to get up my slides. Hopefully you can see them okay.
Yep.
Great. So thanks so much, Kitty, for the very kind introduction, and to Peggy for the amazing overview of what's such a complex topic. I thought you did such a great job at conveying a lot of the nuances with genetic testing. And I'm hoping to broaden the topic a little bit to looking at tissue testing, so testing of the cancer, as well as other biomarkers that we now have available to us. Let me see if I can advance. My slides aren't advancing on your side, are they?
No.
Yeah.
In the bottom left, you should be able to see the little arrows.
Let me just try one more time. Okay, hopefully there we go. So these are my disclosures. So this slide provides an outline of some of the topics that I'm going to discuss. And I hope that I'll be able to give a little bit more discussion of what are the benefits of testing, what type of biomarker testing we have. And I'm also going to look at not just ovarian cancer, but also endometrial and cervical cancers. And then the different types of testing that we might be able to do to help predict response to different treatment options that are available for our patients. So one thing to start with is ovarian cancer, and there are many different types of ovarian cancer. The most common type is the high-grade serous ovarian cancer. And when we use the term ovarian cancer, we're typically also including fallopian tube and peritoneal cancers, because these cancers behave very similarly. And in fact, it seems that a lot of ovarian cancers start with mistakes or changes that occur in the fallopian tube and get spread to the ovary. Another way that these cancers can start is in an abnormality within the cells, such as in a spot of endometriosis, and they can also that way spread to the ovary. So we have a lot of different types. And when we're thinking about genetic testing, we do consider the type of cancer that the individual patient has. So because there are certain genetic mutations or genetic mistakes that are associated with histology. So high-grade serous, it's the BRCA one that we all know, BRCA1 or 2, and that tends to be the most common mutation we see. But sometimes for the more rare histologies, such as endometrioid or some of the clear cells, we can see mistakes in genes that are associated with Lynch syndrome. So it's something that very important that we do consider. All patients with ovarian cancer should be offered genetic testing. That is really important. And over the last 6 to 4 years, all the lead organizations have made very strong recommendations that every patient who has a diagnosis of ovarian cancer should be offered genetic counseling, regardless of their family history or their age. There are multiple benefits to genetic testing. The first reason for doing it is, well, the presence of, for example, a BRCA mutation can help us determine the best course of treatment for that patient. Additionally, the presence of a BRCA mutation also is important in terms of prognosis, and it also provides us the ability to offer cascade testing, or that's testing for other family members, where relatives who do not have the cancer themselves might be able to undergo testing for that particular mutation or that particular change in the gene. And then that could help inform future testing for that individual's own cancer risk. And also for any of our patients, it can also help us determine whether or not we might be concerned about cancer developing in other organs. So there are a lot of really important reasons to do genetic testing. There are different genes that we can look for, and nowadays most of our patients are offered multi-gene testing. So it's not just BRCA1 and BRCA2, but we also look at some of the rarer mutations, such as the BRIP1, the Hrd, or the PALB2 gene. So these are often, and also the Lynch ones are often offered in a panel of testing for a patient who has a diagnosis of ovarian cancer. And so why should we not just test people who have a positive family history or, those kind of things? Well, unfortunately, it seems that even in those who don't have a family history, there can indeed be a BRCA mutation found. And also even the type of cancer, we used to think that maybe you should only offer BRCA testing to patients with serous histology. But what has become clear is that the rarer histologies can also be associated with genetic mutations. And so nowadays we offer it to every woman who has epithelial ovarian cancer. I will say though that there is a ways to go, because it still seems that even as recent as 2018, that over 50% of patients in certain parts in the US are still not undergoing germline genetic testing. So it's really, really important that we get the message out there so that our patients can benefit, and also that their family members also may have the opportunities to intervene if they themselves also carry a germline mutation. So in terms of the multi-gene panel, the other great thing that has come about recently is that for those kind of very rare types of ovarian cancer or GYN cancers, we have now been able to find germline mutations that can be associated with them. And this again offers us another opportunity, not only to test family members so that we could hopefully intervene before a cancer develops, but also for the individual when we're thinking about treatments. If we know what the driver mutation is, then we can consider targeting our therapy towards that. So that's really great to be able to think about a rare tumor and then make sure that we focus our clinical trial or our future treatment options development towards those mistakes that may be driving the tumor, and help come up with effective treatment options for our patients with these very rare diseases. So I was just going to give a little bit of an overview regarding what germline means and what somatic means. Well, germline usually means that what we're doing is we're looking for mutations that are hereditary, so inherited from the mom or from the dad. And in general, these are present in all the cells in the body. But there's another type of testing we can do, and that is testing the tumor. So we're looking at the cancer. And so the idea here is that mistakes can happen in the cancer itself, but are not present in all the other normal cells. And one of the most comprehensive ways of doing testing is to do paired. So we submit a sample of normal tissue and also the cancer at the same time. The normal tissue could be saliva or blood, or it could in fact be some biopsy from a normal area near the cancer. And then usually for the cancer, we're submitting slides, unstained slides or block of the cancer to the molecular pathologist. And then they are able to very carefully review what the sequencing is in the normal tissue and then compare it to the cancer. If the sequencing is present in both, the abnormality is present in both the normal tissue and the tumor tissue, then we're thinking that this perhaps may be a germline mutation. If it's only present in the cancer or in certain cells within the cancer, then we're more thinking about tumor or somatic mistakes. And both of those things are really important. For example, if we identify a germline mutation, then that means that we can offer our patients, we can offer the patient themselves perhaps guided treatment options. For example, with BRCA mutations, we now have the PARP. For certain mutations associated with Lynch syndrome, we have great immunotherapy options. So there are a lot of things that we can think about, but also for the patient's family members, we can also offer additional testing and we can enroll them in high-risk screening programs. So that becomes really, really helpful. So 15 to 20% of patients with ovarian cancer do indeed have a germline mutation. And as I explained, nowadays we offer multi-gene panel testing. So we have the opportunity to look at a lot of different genes, as Peggy has alluded to. And it's always a good idea to check with your health care provider if indeed you require up-to-date testing. Have you had the multi-gene panel, or for our patients perhaps that maybe only had the founder gene mutations checked in the BRCA gene, perhaps there is an opportunity to do a more thorough analysis of the BRCA gene. But then another thing that nowadays we're looking at, and also for ovarian cancer helps guide treatment options, is a thing called homologous repair deficiency. And so that's kind of the way that cancer has evolved, and there are certain things that they can look for in the tumor. I will talk about that a little bit later in my talk. One question we frequently get is, what are the different options for germline and somatic testing? And it will suffice to say, this is just a little postcard that is available for everybody. It was a joint initiative with the Society of Gynecologic Oncology and also the American Community Cancer Centers. And it just outlines some of the assays and gives you what type of tissue is needed, whether it's blood, what type of testing, is it germline testing or somatic testing, how is it billed to insurance, what are the costs. So I think this is something that is available freely to everyone and helps provide a starting points. And a lot of institutions, including my own, have our own in-house genetic testing. So for example, at MSK, we have impact testing, and a lot of the other large cancer centers also have very similar testing options in theirs. So why is it important? Well, in fact, BRCA mutations in ovarian cancer can help predict response to treatment. And so we have seen that there are drugs called PARP inhibitors. They're often either given after somebody has responded to platinum-based chemotherapy, or they can also be given as a treatment options. But another thing that a BRCA mutation can predict is we often know that those patients are more sensitive to having their cancer respond to platinum-based chemotherapy. So all in all, this information can be really, really helpful for the patient and their doctor when they're deciding on future treatments. A newer test that's available is called Homologous Recombination Deficiency, or HRD is what it's frequently called. And that's like a scar that is seen in the kind of the genomics of the cancer. It's almost like a record of what happened with the cancer. And so over time, we can see these changes, and there are a lot of different tests that are available. In general, one of the more frequently common ones known is the myriad one, but there are a lot of different ways of trying to figure out how to determine what happened with the cancer and predict what this kind of scarring looks like. And nowadays, some of our treatments, especially for upfront therapy for ovarian cancer, they are often, it's very helpful if the patient does not have a BRCA mutation to order a Hrd test to see if they might derive more of a benefit from a PARP inhibitor than a patient, for example, who does not have homologous recombination deficiency. So this is a newer test that is more recently available, and that does help, especially in the upfront setting for advanced ovarian cancer, to guide treatment once the patient has completed their chemotherapy. So moving on to endometrial cancer, well, the good news here is that we also now have a lot of different options for molecular testing for this type of cancer. And nowadays we do poly testing. We can check and so that's just a certain way of looking at mistakes in the genes in the cancer. We can also, under the microscope, do immunohistochemistry testing, looking at the DNA mismatch repair proteins. Usually they should be present. It's abnormal if they're absent, and that then often warrants further genetic testing to determine whether or not the cancer may be hereditary, or have we an explanation for why we weren't able to see those proteins. And then there is further testing that we can do. So again, looking under the microscope and doing a special test called P53, that also helps us subtype our cancers. And why is it important? Well, when we figure out how to break endometrial cancers into all these different subgroups, it actually can help us predict outcomes for patients and also perhaps guide treatment. So one thing that we would love to do is avoid unnecessary treatment. So for those patients with poly mutations, it may be possible that we may in the future be able to identify patients who perhaps don't require chemotherapy. Or we may also see signatures that suggest to us that even though cancer is very early stage, that we're a little bit concerned that it may be higher risk, and therefore we may decide to give additional therapy. One thing that's very clear is that there is an important test that we can do, and it's called microsatellite instability. So that's a test that we would run. It is sent with the at our institute, we send it with the tumor genomic profiling, and it does help us decide if a patient is very likely to respond to immunotherapy or not. So we hear the words MSI high or MS unstable, and that in general suggests that the patient may benefit from immunotherapy. If patients don't have this MSI high status, then we often try and think of other ways to treat the cancer. We may have to combine a second drug with immunotherapy in order to make it more effective. Another thing that we're more recently able to look at is the number of mutations in a cancer. So if there's a lot of mutations in a cancer, then that can help us predict that perhaps immunotherapy will be helpful. In general, in ovarian cancer, it does not tend to have a high number of mutations. It's actually quite rare. And I would say the same for cervical cancer as well. Endometrial cancer, especially those associated with Lynch syndrome, can have a very high tumor mutational burden. So it's something that we're looking closely at. And it's nice to be able to offer immunotherapy to our patients if in fact the cancer shows. So there's now an FDA approval if the tumor mutational burden is greater than 10. Moving on to cervical cancer, well, as we know, HPV infection is ubiquitous, and unfortunately, it can be the driving cause for cervical cancer for a lot of our patients. So the amazing thing is that we've already seen that great benefits that the Hpv vaccination programs have offered, and already in countries such as Sweden, and they have published their data showing that their Hpv vaccination has already dramatically cut down the number of cases of cervical cancer. And so I want to really highlight that prevention is always better than cure. So it is great that we have access to this vaccine, and hopefully in the US as well, that we will also see the great benefits of vaccinating our young our children. In general, the HPV vaccine is most beneficial when it's given in the preteen, early teen population. So it's just something really important, and it has been shown to be safe. And the other thing that is really important is, even though we have vaccines, we should not forget the importance of screening and regular screening. We can now detect HPV infection and abnormal cells, and we can detect those cells in the cervix. So when we do a pap smear, we can check for the abnormal cells, and we can also check for what's called high-risk human papillomavirus, or HPV infection. If caught early, cervical cancer has a very, very high rate of successful curing patient. And so HPV itself is a really, really important biomarker that we now have, so that we can identify these cases early. Another thing that we can use, and more so, it's still a little bit exploratory, but for example, in cervical cancer, PD-L1, or that's kind of, that is a programmed death ligand 1, that's what it's called. PD-L1 can indeed, for cervical cancer, predict response to certain immunotherapy drugs. So that is something that we are now routinely doing on any of our patients who have recurrence of their cervical cancer. We are testing their cancer to see if they have this important biomarker, as it can then predict response to immunotherapy in the recurrence setting. Tumor markers. So for our GYN cancer, CA125 is the validated marker that we use. And just to explain a little bit about what CA125 is, well, CA125 is actually comes from a big glycoprotein, or big protein that sits on the surface of the cancer cells. And then a bit of it is cleaved off and released into the blood system, and that's called the CA125. There are a lot of things that can affect, how high the level of the CA125 is. And sometimes, even in my practice, I sometimes see a rise in the CA125, even in patients who go on to derive a benefit from whatever treatment they are on. So we tend to look at tumor markers such as CA125 as a piece of the puzzle, but we don't usually make treatment decisions just based on the CA125 alone. What's really important is how the individual patient is feeling, and perhaps what their imaging shows. But CA125 can be helpful to monitor, but it is not the marker that we use to make all treatment decisions. It's just a little piece of the puzzle. There are other markers too, such as HEA4, but CA125 really is the key one that has been validated. For uterine cancer and cervical cancer, we don't tend to follow it as closely, because it's a little bit more unpredictable, and it's really just for ovarian cancer that it's an approved marker that we use. Some newer things that we're looking at is, well, what about, could you look for evidence of the cancer or the tumor in the bloodstream? So what's called circulating tumor DNA. And so the cancer itself could release little particles into the bloodstream, and perhaps we would be able to look at those abnormal cells and then sequence the DNA. And the idea is that if there isn't a lot of cancer in the body, perhaps you won't see a lot of the circulating DNA, but if there's a high burden of disease, then this might herald this might indicate that there's a high burden of disease. Unfortunately, for GYN cancers, we have not been adequately able to isolate, and this is still all very experimental. It's not something that we've been able to use to guide treatment decisions. So perhaps it'll be something that we'll use in the future, but at the moment it is entirely experimental. And so what I wanted to also really highlight is how hopeful and bright the future is. We have so many targeted therapies. There are a lot of different biomarkers that we're looking at, and I'm really hopeful that all the clinical trials that we have will eventually continue to improve treatment options for our patients with gynecologic cancers. And I just wanted to give a shout out to my colleagues, and I also really appreciate the opportunity by Cher and for everything they're doing to advocate for our patients. And I'm happy to take any questions with Peggy.
Thank you so much, Dr. O'Cearbhaill. Really interesting, both of these presentations, and tied really well together to explain the differences. And now I fully, totally understand the difference, which I always understood to a degree, but now you made it so clear with genetics and genomics. So let's start the Q&A. You can still submit questions at the Q&A section in the bottom of the screen. We will unlikely be able to get through all the submitted questions because we also had some others submitted ahead of time. So we'll do our best to do as many as we can. I'm going to start with one because several people asked this about a general timeline of when next generation testing started. Somebody had genetic testing about 5 years ago. They weren't sure if this was next generation or PCR. And actually, there's a related question with the commercial DNA testing like 23andMe and whether that should be relied on instead of a full genetic testing panel.
So with 23andMe, I can definitely definitively say you shouldn't rely on their testing for making medical decisions. And that's not only what we say, but also what 23andMe says. They say, please confirm anything you find in our test with a medical grade test. And so it's really important, especially as the cost of testing, getting medical grade testing is reduced so significantly. Don't rely on 23andMe if you're looking for medical information. They're fine for finding long lost relatives and, and those sorts of things as well. Ancestry, am I really 100% Jewish? All of those are good questions for 23andMe.
Yeah.
In terms of next generation sequencing really came into play more than 5 years ago, back when panels were first offered. But you can't ever be sure exactly what the technology is of every test that you had done. And so, while next generation sequencing was available 9-10 years ago, it may have been that the lab where your testing was done was not using that. So it's always good to check with your healthcare provider, bring a copy of what your testing was, and they should be able to answer that question.
Thank you. There were a few questions along these lines as well. Do tumor characteristics change over time, and should repeat genetic testing be done throughout treatment, or if you get a recurrence? Yes, and yeah, that's the basic question.
I would say at the moment, we don't see too many changes, and so repeated testing is often not required. I will say a biopsy, though, is often a good idea at the time of recurrence, say, for example, for ovarian cancer. We just want to make sure that what we're seeing on the scan or what we're concerned about is indeed a recurrence. So usually at first recurrence, we would obtain a second biopsy. Often now we are offering genetic tests, so germline genetic testing at initial diagnosis. I saw a question there saying, can you do it while you're undergoing chemo? Absolutely. It's as soon as we can do it, it's really helpful. And then we often, at the same time, will send off a sample of the cancer and that we obtained. In order for the tumor testing to be helpful, it's good to have quite a large sample of tumor to be able to give the molecular pathologist. So often that debulking or the cytoreductive surgery is a great opportunity to send tissue for tumor testing. We don't necessarily have to do repeated testing unless there is a good reason to, as often we don't really see changes within the tumor genetic makeup that would make a difference in terms of our treatment options. In the future, though, that may change. Ideally for the patient, it would be lovely to be able to offer repeated testing with bloods and not having to do repeated biopsies because they're obviously invasive. But where we are at the moment, in general, we do one comprehensive analysis, and unless there's a reason such as enrollment in a clinical trial that may pay for that testing, insurance at the moment usually will provide one kind of cover testing that will help guide treatment, but not necessarily cover repeated testing.
That's really good to know. Thank you. And I know this particular question is of a lot of interest to our uterine cancer patients. Does BRCA2 increase the risk of uterine cancer?
So the evidence does not seem to show that there's a significant increase in uterine cancer risk with BRCA2. There seems to be a little bit with BRCA1, and studies were difficult because there were confounding effects of tamoxifen, which could be increasing uterine cancer risk. The risk is subtle. And so this is, again, something to talk about with your doctor if it's something that you in particular need to be concerned about.
Yeah, I agree. And your doctor then would also take other factors into account, and that, you know, from your personal history and perhaps family history. So it's always a great idea just to any kind of concerns like that, just address them with your healthcare provider and your team.
Thank you. Can you talk a little bit more about the other genetic mutations like PALB2 and RAD51C, and also the Lynch syndrome related ones?
So most of, so I would say PALB2 it's named a partner and localizer of BRCA2. So I like to think of it as BRCA2's pal. And so the pattern we see is somewhat similar to BRCA2, but not, the risks are lower. So there's a risk probably for pancreatic and for breast mainly, but probably less for ovarian and prostate. The RAD50, there's two RAD genes, 51C and 51D, and they mainly increase risk for ovarian cancer, but not as much as BRCA1 and 2, and not so much for breast cancer. And so for many of the other genes that we look at, they cause a much more moderate risk, and the particular types of cancers that are increased will be different. And so it's really important when you get a result that's positive for something that you speak with a genetic counselor and find out what are really, what are the risks with this inherited mutations, what screening should I be doing differently, and are there any surgeries that I should be considering? Because those are really individual questions. And Lynch syndrome has very little to do with breast cancer. It's mainly colon and other GI cancers, and uterine and ovarian cancer. And so again, talk to your healthcare providers about your specific results. There are different genes that predispose to Lynch syndrome, and depending which gene also changes how much risk there is. Some of them are more moderate than others. So very individual question.
Very good to know. Thank you. And actually, somebody just asked what tumor markers are most related to ovarian cancer, and we know about some of those, but if you could explain a little further on that.
So this CA125 is the typical one that we use, unfortunately, as a screening test. So for somebody who doesn't have ovarian cancer and is part of the general population. So the risk for ovarian cancer is about 1 in 80 for women in the general population. CA125, and there's been huge studies of thousands of women, and CA125 as a screening test has not been found to be an effective screening tool. So it's not that it doesn't have its role, it absolutely does. And I check it in my patients who have ovarian cancer, and I use it as a little piece of the puzzle when I'm monitoring their therapy, but it's only a small, it's a marker, but it isn't the be all and end all, and it doesn't, sometimes it's not elevated in patients who had very advanced disease, and sometimes it can be extremely elevated in patients who are very well and who are actually doing well on their treatment. So it is a marker that we use, but it is not an effective screening tool. I will say for women who have a positive family history, or there's a concern that they're at high risk for ovarian cancer, there are high risk clinics, and it would be important to enroll in one of those with a specialized GYN oncologist, and they would be able then to individualize what type of screening would be appropriate for that person.
Thank you very much. We've had a couple of questions about Lymphaza. is there a test to determine whether Lymphaza is working? This is a little bit partly related,
Yeah.
and
So-
any other testing that can be done during that process.
So Lymphaza, the generic name is olaparib. It's a PARP inhibitor, and there are 3 PARP inhibitors that are approved at the moment. We do know that patients who have BRCA1 or 2 mutations are most likely to derive, are the group that are most likely to derive benefit from a PARP inhibitor. That said, we do know that there are patients who don't have a BRCA mutation who also derive benefit. So there's a newer test for patients who have newly diagnosed advanced stage ovarian cancer. It's called Hrd testing, and it comes up with a score. And if the score is high, or their cancer is determined to be, yes, Hrd positive, so homologous recombination deficient positive, if they are positive on that, then the thought is that that patient might be in a group that's likely to derive benefit from a PARP inhibitor. Those who are Hrd negative are the group that are least likely. And so when we're thinking about the risks and benefits, you know, PARP inhibitors aren't without toxicity. They can be harsh on counts. There's a very small risk of leukemia and a rare condition called myelodysplastic syndrome. So when the doctor's trying to weigh up the risks and benefits, having that extra testing can be quite helpful. And you know, it's always a personal discussion between the individual and their healthcare provider.
That actually leads perfectly into another question that someone had, that where they live, the HRD testing is not available, and they were wondering if they should send a sample somewhere else, or is there some other way that if it's not available where they live?
Yeah, I mean, we're only using it in a unique setting of, so somebody has to have stage 3 or stage 4 high grade cancer, and it's for patients who've had a response to platinum-based therapy. I would imagine insurance would not cover it in the multiple recurrence settings, because there isn't any data to support its use in that setting. There's a very rare situation where a patient has cancer that has recurred greater than 6 months after their last platinum-based therapy, and they've had more than 4 chemos that you can be used for. That's based on a study with a drug called niraparib. But I would look why the testing wasn't being covered, and I wonder, is it because it was in the recurrent setting? And it really wouldn't be indicated in that setting at present.
Okay, thank you.
But I would encourage everyone to lobby their local representatives as well, because it should be available. You know, it's part of the NCCN guidelines now, and so in the right circumstances, it's something that hopefully we should be able to offer everyone.
That's really good to know. Thank you. I think this is going to probably be the last question. What does it mean if a mutation is found and it has not been identified yet as causing disease?
That's from a germline point of view, Peggy can speak to, and then I'll speak from the cancer point of view.
Yeah, so very often when people have testing, there's something found that's called a variant of uncertain significance. And that means that they found something that's a little bit different in your DNA, but they're not sure if it's enough to cause a problem or not. And it's a difficult result to get back. Those results can, over time, be reclassified. More often than not, they get reclassified as normal, but they do occasionally become reclassified as something of concern. And there was a story in the news this weekend about this related to Chris Evert, if anybody wants to take a look at that story. In her family, there was an uncertain variant that was reclassified to be of concern. So it's very important to not overreact to these uncertain variants, because usually they're not important, but make sure you stay up to date with your doctor about what they might mean.
Yeah, and it's often helpful to check in with the doctor every few years just to see have things changed, you know, or wherever the genetic testing was done. And the other thing that we often see is mutations or mistakes or alterations in the cancer itself, but they may not be important in terms of like driving the cancer or having the cancer grow, and we may not have treatment options for them. So certain mutations, like the BRCA mutation, that has a treatment option that we can use that information to make treatment decisions. but there are other sometimes mistakes or alterations that we see that won't help the doctor, won't guide therapy, and may not actually be important in the way that the cancer will develop.
Thank you very much. Well, I'm afraid we're out of time, so I wanted to really thank Dr. O'Cearbhaill and Peggy for a really informative program, and hearing both sides of this was really interesting. And thank you to everyone who participated and submitted questions. Please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in a follow-up email, and all survey responses will be anonymous. And I also want to thank Sharsheret again for your partnership in producing this webinar, and we're grateful to have you as a partner. And thank you all, and have a great afternoon.